Right. Hello, everybody, and thank you so much for joining us tonight on this Wednesday evening. My name is Michael York, and I'll be your moderator for the webinar tonight. We do like to make this interactive, so if at any point you do have any questions, please don't hesitate to go ahead and use that question and answer function down below, the Q&A. We find that's the most productive as opposed to like the chat or the hands raised. That gets a little complicated, so the question and answer function down below is the best thing to go ahead and utilize. And we'll be answering those questions throughout tonight's webinar. And we do have a great one on hand for you tonight entitled Factors Affecting Cataract Surgery, which will be presented by our very own Dr. Behnaz Rouhani. Dr. Rouhani specializes in cornea, cataracts, and refractive surgery, is a specialist in all three areas. So a lot of extensive knowledge on tonight's topic. Just a little bit of background before we go ahead and hand things over to Dr. Rouhani. She received her medical degree with high honors from Shahid Beheshti University of Medical Sciences and conducted her clinical research fellowship in ophthalmology at the Rocky Mountain Lions Eye Institute at the University of Colorado. After her time in Colorado, Dr. Rouhani completed her ophthalmology residency at Drexel University College of Medicine in Philadelphia and followed her residency with a fellowship in cornea and refractive surgery at the well-known Ross Eye Institute, the State University of New York. So we're very thankful to have Dr. Rouhani a part of Harvard Eye Associates. We're very happy to have her on with presenting for tonight's webinar. And I will go ahead and hand things over to Dr. Rouhani herself.
Thank you, Michael. Good evening, everyone. Thanks for joining us tonight. I'm very happy and honored to be here tonight to have a very casual, but also, very informative, hopefully talk tonight with each other. Please feel free to ask any questions that you might have or provide any input. Would be happy to answer any questions in between the talk. Please let me know. And hopefully this is going to be a very good and informative talk. So I'm just going to talk about a very important thing that we should all know about, things that could affect our cataract surgery outcome. So let me just go ahead and, okay. So I'm sure a lot of you guys might come up with this question that what factors affect the final visual outcome following cataract surgery? Is it just the only lens that should come out and, then you're going to be seeing, fine? Or there are other things that are important to be considered prior and after cataract surgery. So why is it important to have complete eye examination prior to cataract surgery? And what actually most of you probably know, when we schedule patients for cataract evaluation, that technically means that we should, examine the whole eye and see what are the important things that we should take care of prior to proceeding with cataract surgery to optimize the outcome. Would cataract surgery alone help restoring the optimal vision? And that's another thing that we're going to talk in a little bit about it. And we are living in an era that we have a wide variety of lens implants out there. And a lot of patients always ask me about, okay, would they benefit from, the multifocal, different versions that I'm going to talk to you about, trifocals, extended depth of focus, or even light adjustable lenses. Would everyone be a candidate for? All right, so how about we talk a little bit about how do we see? Our eye works as a camera. The very front part of the eye, which is the clear layer, dome-shaped area, is cornea. And in front of that, we do have a tear film. After that, we do see the pupil, and the color part of the eye, which is iris. Then the lens is sitting behind the color part of the eye. Both tear film, cornea, so as the lens, they focus the light onto the retina. And then the retina basically sends all the information to the brain and the image is then formed. Therefore, in order to see very well, it's not just about the lens that needs to be clear, or the cataract is kind of like cloudiness of the lens that as we age. So if we remove this and replace it with a nice implant, a clear implant, we need to have a good retina, good nerve, good cornea health in order to be able to see very well. All right, so let's talk about a few important conditions affecting visual outcome post-cataract surgery. Very well known to most of our patients, dry eye disease is one of the very important things that should be evaluated prior to cataract surgery. I do get a lot of referrals with extensive amount of dry eye feeling, dry eye disease, and problems after cataract surgery, and they feel they didn't have it prior to cataract surgery, and cataract surgery is the cause of it. I'm going to get into it a little bit further later on. Cornea conditions. And again, the cornea was the dome-shaped clear area, the window to the eye that I just showed you. Different cornea conditions can affect the visual outcome post-cataract surgery. Well, I'm going to go in a little bit shortly about how the cornea anatomy is and how many layers we have. We have conditions that can affect each layer of the cornea. So that is very important to get it evaluated prior to cataract surgery. From very front part of the cornea to very deep layers of the cornea, there are different conditions that are important to be assessed, such as epithelial basement membrane dystrophy, which is a genetic condition that affects the very first layer of the cornea. We do have Salzmann nodular degeneration, which are like lumps and bumps on the surface of the cornea, affecting very, front layers of the cornea, basically. Fuchs dystrophy is not uncommon, and it's very important to be evaluated prior to cataract surgery because it affects the very inner layer cells of the cornea that are in charge of not letting the cornea to go swollen and keeping the cornea tissue clear. Radial keratotomies, a lot of you guys might have those done. They're not being done anymore. They're out of, the newer techniques now. They're replacing radial keratotomies, but there are, they were procedures that used to be done for patients who were very nearsighted to flatten the cornea to improve their vision. But unfortunately, they cause some weakening and they regress. And the scar formation can affect the outcome post-surgery. So we have to keep in mind a few further measures prior to proceeding with cataract surgery in patients with RKs. Scars due to different reasons, from infections, from inflammations, are again very important to be evaluated prior to cataract surgery. Keratoconus or cone-shaped cornea is another condition that I'm going to talk to you about. Again, patients with having that will have different visual outcome following surgery and would not benefit from a lot of the implants that are now out there. Band keratopathies are some deposits on the cornea that I'm going to talk about those a little bit further. And pterygium or surface art is the growth over the cornea that one also can affect post-surgery outcome if we do not take care of them on time prior to surgery. Other parts of the eye, such as retina, can also affect the cataract surgery outcome, such as diabetes, whether diabetes has affected the retina or not, and macular degeneration. We're not going to get to the retina section tonight, but those are why we dilate patients prior to proceeding with cataract surgery whenever we see patients for cataract evaluation, because retina health is also as important as everything else in kind of like setting the realistic expectation and kind of like predicting the post-surgery outcome. And glaucoma, which is disease of the nerve. And again, that part is another whole section that at some point, Dr. Wong or our amazing glaucoma team, Dr. Gujral and Dr. Timourian will go over them with you. All right, so a little bit about dry eyes. Okay, so dry eyes, dry eye disease is a very common condition. Sometimes it's very asymptomatic. Patients don't have any sort of symptoms, but when we take a look at the eyes, we can see all those little dry spots that you see on the cornea here and extensively on the surface of this cornea. We have to address this even if the patient is asymptomatic. And that's why a lot of patients after cataract surgery think that, okay, I never had any issue. This was not addressed. Now I have a lot of issue, because if it is left untreated, it will become symptomatic at some point, especially after cataract surgery, which technically can put us at risk of a little bit of a flare-up of dry eye conditions. Again, it's very important to be diagnosed and also manage and control prior to cataract surgery to make sure we're going to not only improve vision post-surgery, but also keep the comfort of the eyes as much as possible. This also will affect the measurements of the implant that we're going to place in the eye while we do cataract surgery. So we need to really have a clear surface to be able to get accurate measurements. The dry eye disease is a very complex condition, and its treatment may take some time before best eye surface health is achieved. So patients should be very, this should be discussed with patients in detail, and patients should be patient to make sure that this is being really under better control before we proceed with cataract surgery, in order to, kind of like get to the goal that we are looking for. Again, as I explained, symptoms may worsen following surgery. All right, so a little bit about corneal layers, because I'm going to go over a few different conditions that can affect the corneas and cataract surgery outcome. I just need to let you know how the layers of the corneas are, and each pathology can affect which layer. This is a cornea here that you see, and this is just like magnified here, so you can see all the layers of the cornea. The very surface layer is epithelium, where we can sometimes easily get scratches, infections, abrasions, erosions that you might have heard of. Bowman's layer is just a little bit deeper than that. Some conditions that I already talked about, such as Salzmann nodular degeneration, can get to that surface. Stroma is the middle layer of the cornea that can be affected by some genetic diseases and dystrophies. Descemet membrane and endothelium are inner layers that can be affected by Fuchs dystrophy, and that's very important to be evaluated prior to cataract surgery. These cells are the cells that do not let the water inside the eye. Over here, we have fluid. So these cells are in charge to keep the cornea very clear and nice. So if they don't work as well, some of the fluid in the anterior part of the front part of the eye can get into the cornea tissues, make this area pretty swollen, and therefore vision hazy. Another section, cross section for those layers. So we have the very surface layer, which is epithelium, Bowman's membrane, stroma, and then Descemet membrane and endothelium, which are the inner layers of the cornea and are very important to be assessed. Fuchs dystrophy, as you see, this is the beam of the machine that we use to examine your eyes. So once we angle the beam, we can go through all the layers as I showed you in the last picture. The very inner layer, or the back layer of the cornea, is where all those endothelial cells are existing. They should be very clear, and you should not see all these little dots. When you see these little dots, probably there is Fuchs dystrophy going on. So we always check the other eye, because this condition is bilateral. It's never one eye. It could be different stages, but it's a bilateral condition. It's a genetic disease. It is autosomal dominant inheritance. What does that mean? That means that, parents can pass it on to kids. After age 50, however, this condition shows itself. So again, it is a hereditary condition presenting after age 50. And as we discussed, it is a disease which the cells responsible for fluid flow in the corneal layers die off. So it gradually, basically, when you see these dots are the areas that those cells are not existing anymore. All right. And early stages may be treated medically with certain drops. We have sodium chloride drops. They're basically salts. They absorb extra water in the corneal layers, or Miro 128. However, if we are deciding to move forward to any sort of surgery in the eye, we have to consider further management and treatment. Advanced stages may require surgical intervention or transplantation of the cornea layers, which we're going to talk about a little bit. Again, you do see some hidden metal appearance of most inner layer of the cornea with Fuchs dystrophy, and this is more magnified area. You do see some dark little dots. These are where the endothelial cells are not there anymore. Okay, so the surgical interventions, years back when we didn't have newer techniques, we used to go ahead and remove the whole cornea and transplant it with the full donor cornea. Thanks to newer techniques and science, we do not need to do that anymore. So previously in the, we're still doing DSEC 2, which is this one. We do have a thicker, kind of like a layer of the donor cornea, which includes not only endothelial cells, but some of the stroma or the mid layers of the cornea too. So it's thicker. Sorry about that. All right. And it does still work well. And in certain conditions, we have to still go with this procedure. But this is the very latest procedure now that we do. Not a lot of surgeons do it yet because of the difficulty of the technique and surgery. But the good thing is that I have been doing it within the past few years, and a lot of great surgeons in California have been doing it and across the nation. And this is associated with just, replacing a very thin layer of endothelium. So therefore has much better visual outcome post-surgery. Okay. And these are not only for Fuchs dystrophy, any sort of a pathology that causes cornea swelling and, issues. These techniques can be done to help save the rest of the cornea and also save the vision. All right, so a little bit about this technique, that it's the latest technique that we do in transplant surgery of the cornea, endothelial or the inner layer cells. As again, we talked about, this is the latest transplant procedure. And it only involves transplanting a single layer of the inner cornea, which is about 2% of the whole cornea thickness. And this is amazing because it's just like even thinner than a skin of the grape. It's hard to imagine, because that's why it's very difficult to, do it. The technique is difficult, but it's very, very helpful once we get to do it. It does have definitely a learning curve for surgeons, but again, once it's set, it is going to be associated with perfect results. And I have been having really, good amount of patients with this technique and surgery, and they're really doing well following the transplant surgery. And again, it's not as performed as the other techniques because of the difficulty. However, it is associated with the best visual outcome compared to the other transplant procedures. It is associated with lower rates of graft rejection and faster healing than other techniques. All right. So a little bit about how I can actually show you a little bit about what we do with DMEC surgery. This is a cornea, so it's the patient who is actually laying flat. First of all, we make a little bit of opening in the color part of the eye, so we do not get buildup of fluid in the front part of the eye following surgery, therefore no further elevation of the eye pressure. We make a very small incision, about 2.4 millimeter. The tissue comes, because it's very thin, it's folded. So we place it in the eye, and they have to use some techniques to unfold the tissue in the eye. And once it's unfolded and centered, we put a little bit of a gas or bubble underneath. So we push that graft against the recipient cornea. The patient should be laying flat to keep the bubble against that transplanted tissue against the recipient cornea for a little while after. And after a little while, the donor tissue and recipient tissue attach, and they become friendly, they become one, and the vision will be normalized normalizes after, once the inflammation is gone. So that's how I basically explain everything. And again, patients will be keeping flat to make sure the adherence will be complete. So one of the pictures I want to show you, this is one of the patients we have in the past. I did the surgery on. So if you see here, so you see the cornea is very hazy here. And you see these little, tiny, teeny darker spots. They're actually blisters from significant amount of swelling in the cornea. So the whole thing here is pretty hazy, even extended to the center. This area is yellowish tone, so this patient has cataract too. So this patient had a combination of cataract surgery and DMAC or transplantation of the cornea. And this is only 3 weeks after the surgery was done. And the patient was very happy, vision very good, and no more swelling, no more intermittent blurriness, and everything really went well. All right, so that was one of the important things. So before I start this new topic, I just wanted to let you know this is one of the very, very most important things that we need to evaluate prior to cataract surgery. The ophthalmologists do not need to be a cornea specialist to pick that up. However, sometimes it's very difficult to pick that up because it could be subtle. So patients after cataract surgery kind of like develop too much of inflammation, and they need to go to cornea specialists to take a look at the cornea tissue and see if they would need, or this is going to be taken care of like by medical intervention. So it's very important to know, because sometimes we can do combination of both surgeries at the same time, like as we did for this case. Sometimes in early stages, when we don't have this much of swelling in the cornea, but we do see that those kind of like bitten metals areas that I showed you in previous pictures, we can go ahead and do cataract surgery, but we have to monitor our patients very closely to ensure that they recover and the cornea will recover from that swelling. If not, then the next step would be DMAC surgery. All right, keratoconus is another condition that affects the most anterior or front part of the cornea. So the cornea should have a very nice and curved, surface. As you can see in this eye, this cornea has a little bit of a cone shape. So the center is basically peaked and thinned out. This is a cornea mapping. It's an imaging that we do to evaluate further. And most of the patients prior to cataract surgery will get this, because we want to make sure there's no significant irregularity on the surface of the cornea. And if there is, we have to address that. Keratoconus, however, is disease that it starts very early on. Usually it's genetic, and it could, we have genetic testings available too, to figure out if any, sort of other members of the family have it or not, and if you should address that early on. Usually starts around late teens and progresses up to late 30s. So by the time the patients get cataract, which is usually around 60 and up, that should be set. So we're not expecting further progression, but it's very important to know if patient has that, because that's one of the things that determine if we can basically place an implant in the eye. Most of these patients, not most of these patients, no keratoconus patient can have a multifocal lens implant, because they're not going to be happy after surgery because of too much of glare and other issues that they might have. However, astigmatism correction can be done during the surgery. So it's very important to diagnose it, even though it's the disease that will be diagnosed mostly a lot earlier than when the cataracts are formed. Again, this condition can cause a lot of glare, light sensitivity, high irregularity, and astigmatism, causing vision decline. So these patients, if they go straight to cataract surgery, get even the simple implant in there, they might not be able to see very well without vision correction with glasses or contacts after surgery. So it's very important to know what conditions you have, to set the realistic expectation and see, okay, what would be the next after cataract surgery? Why am I not seeing better after cataract surgery? Well, there are conditions like this that even after cataract surgery, things are going to be brighter, better, but still vision correction with glasses or contacts will be needed. And again, initially, early on, when patients are younger, milder cases may benefit from special contact lenses and they will be fine. However, the advanced cases may require corneal transplant surgery. Thankfully, these days, we have a newer technology that was just not too long ago FDA approved to be done with patients when we catch the disease on time and we don't want any progression. Cross-linking is a procedure that can prevent progression of the disease because this disease is such a progressive disease which starts in late teens and progresses up till 40 years of age. So if we get to that high progressive stage of it, we might not be able to do anything other than transplantation. But thanks to cross-linking, we can do it, pick it up on time, take care of it on time, and not let it progress. So that's another kind of like, beautiful thing that we have in this era, thanks to science and technology. And we do it often here. I do get a lot of keratoconus patients. So they will have a lot better visual outcome when they get to the time that they would need cataract surgery, even though it would not be for another 20 or 30 years after once I am actually seeing them now, but this is going to protect them and prevent poor vision outcome after surgery. What's cross-linking? It's a very simple procedure. Basically, we use a riboflavin or vitamin B2 and ultraviolet radiation or light to basically make the collagen bonds of the cornea more stable rather than letting them go weaker. So what it does, it's a very painless surgery, basically, and doesn't need any general anesthesia. It's in-office procedure. We put the vitamin B2, and then we shine the ultraviolet light. With this, you see that all the crosslinks and collagen fibers are very low in patients with, or weak in patients with keratoconus, but that actually provides a lot of basically bonds and more of crosslinks and actually stop the progression. This procedure, however, will not make the vision better, but will stop the progression of the disease. All right, the next condition that can affect the post-cataract surgery outcome is very important to be picked up prior to surgery is epithelial basement membrane dystrophy. This is also a genetic condition. Sometimes is as easy to be picked up as soon as we take a look at the eye. And sometimes very faint lines or dots may be seen, and then we need to really pick it up and take care of it, especially if it is in the center of the eye or in visual axis. As you can see, what you see here, they're like fingerprint maps, kind of like sort of opacities or dots here that basically once the light hits them, it kind of like can cause a lot of glare and then refracts from those areas. So no matter again what, you're gonna go ahead, would take the cataract out after cataract surgery. Patients are not happy with this. If the patients would like to go ahead and have multifocal implants, is another also important thing that we need to take care of this before we consider multifocal implants for patients, because if we do not take care of this, or we miss this for patients and we put like a multifocal, trifocal implant in there, patients might have a fine vision of 20/25, 20/30, sometimes even 20/20, but they are not happy with how they see things or the quality of their vision. So it's very important to be evaluated prior to surgery. Again, this is a genetic condition that affects the superficial layer of the cornea. And this condition may interfere with the strong adherence of the surface layer to the more inner layers. So around 10% of the patients are very prone to get abrasions or like scratches easily, and the surface layer can slough off pretty easily if the eyes are dry, especially. So this condition may lead to blurry vision, light sensitivity, and painful recurrent corneal erosions or scratches. Surgical management may be recommended in order to obtain more reliable measurements. And that's another thing, because you're going to go through a lot of tests prior to cataract surgery. And those are to measure the implant power that we're going to put in the eye so patients can see very well. If you have a surface that doesn't really have nice and smooth and clear area, those measurements could be off, and then we could, make an error in measuring the implant power. Surgical management may include cornea superficial layer removal. So what we usually do is a very simple minor procedure. We technically go ahead and remove the very surface layer of the cornea, let it regenerate again. So therefore we have a nice and smooth, surface. The other procedures can be done, or these procedures can be combined to help with further improvement of the corneal health, such as lasers. Phototherapeutic keratectomy is one of the main ones that has been going on, very useful for this condition and a lot more other conditions of the surface of the cornea, very minor surgery to improve visual outcome. Band keratopathy is another condition that, again, this is a cornea. Look at it, you have some deposits on it, mostly because of calcium in patients who have hypercalcemia or hyperphosphatemia, and patients with kidney disease and a lot of inflammation. These can be seen. So again, just imagine you would know you have this on the surface, and then cataract surgery is done. You still cannot see very well because this should have been taken care of prior. Plus, this will affect the measurements as well. So again, that's another thing that needs to be managed beforehand. It could be seen as yellow-white fine deposits, that could form in the periphery and then extend to the center. Some patients would be non-asymptomatic, and sometimes if they get thicker and thicker and more, kind of like deposits happen, they can feel it. So they come with pain. It can be seen in the setting of chronic eye inflammation, and again, hypercalcemia, hyperphosphatemia. If they had retina surgeries with silicone oil, and if they have been using any lots of drop with preservatives, that could also put patients at risk of developing band keratopathy. This is the procedure.
Dr. Rouhani, just like we have a question with regards to kind of eye irritation, like you were mentioning, and this is prior to cataract surgery, a particular patient didn't have issues with dry eye or sensitivity. Mm-hmm. However, since surgery, their eyes seem to be very dry. And although using eye drops, there's a little bit of improvement, but it's not like it was prior to surgery. Mm-hmm. Would that be in relation to any of the most recent topics, or potentially another solution to assist with that post-cataract dryness?
Well, that's a very good question, because again, we do see a lot of patients with that. Again, I get a lot of referrals with having symptoms after cataract surgery. Again, this, any sort of eye surgery can put patients at risk of becoming symptomatic from the existing dry eye disease, which was not really seen much on clinical examination prior to surgery. So, sometimes we just take a look and see, okay, the cornea is clear, and they know none of those spots that I showed you earlier and the slides, the dry spots, and patients not symptomatic. So basically it's overseen sometimes. So I think most of the reports have shown that those patients have some level of gland issue or tear production issue prior to cataract surgery, which cataract surgery is sort of a trigger to basically, wake it up or become symptomatic. So, that's why I usually tend to really be on a more aggressive way. Even when patients say, I don't have dry eyes, I don't feel I have dry eyes prior to cataract surgery. If I do see even mild symptoms, signs, not symptoms, mild clinical signs on exam, I will start treating, because that's what we've been seeing after cataract surgery. And the exact reason is not known why cataract surgery itself triggers that minor, baseline disease to, kind of like wake up and show itself or become symptomatic. But that's the reason that we are now more aware of this. And we're just trying to get anything that we see, even mild, under control before we proceed to cataract surgery. I had a patient today, even, was for cataract evaluation. She was eager to get the cataract surgery done. Asymptomatic. She wouldn't even believe when I said, you have dry eye condition. You are prone to become symptomatic in the future because of how their glands, the oily glands or meibomian glands looked, because how the eyelids were. Because again, that's a very huge topic that we may kind of talk about, that the dry eye disease prior to cataract surgery. I'm not, it's kind of like outside of our time that we have for tonight, but we do have a lot of glands, the oily glands in our lids. The patients don't really think about the eyelid health. They think about eyeball health. And that's, our eyelids are part of the eyeball. And not only that, when we see patients are fine, we say, okay, let's go ahead, because they're more worried about their vision. So let's go ahead and do it. But then we'll see after surgery, we have what we call 20/20 unhappy patients. That means that they have a good vision, but they're not very, comfortable. And that can happen. So yes, it could be associated with underlying blepharitis, which is inflammation of those glands. It could be associated with underlying medical issues, changes of medications for patients. So all those things, even the eye drops that they will be on for a little while, those things can, kind of like affect. And yes, it's going to take time. They're not going to really, improve with just lubricating drops for a little while after cataract surgery. They will definitely get better, but it will take some time to get the condition under control. I hope this answered their question.
Great insight. Thank you.
Yeah, is there any other questions, or should I proceed?
Not as of the moment.
Okay, all righty. So superficial keratectomy was the same procedure that I talked about. We basically will go ahead and remove the very kind of like surface of the cornea, surface layer of the cornea, which is very weakly attached to the inner layers. You see, like, this is not a very perfect picture because it's a little blurred, but it's just it's like a Q-tip sort of a thing that can, just by rubbing it against the cornea, we can easily slough off that layer. That actually tells us this layer is not really fine and healthy, is not greatly attached. So basically we'll remove the diseased layer, and then we open up a nice clean center, put a contact lens over to promote healing process. Once the cells come together and form a nice and smooth surface, the patient can see much better, and the measurements for cataract surgery and implant will be much better. Salzmann nodular degeneration, which I mentioned earlier on, there are some basically lumps and bumps on the surface of the cornea, which are hazy, like looking like scar tissue formation. These also can kind of like affect how the light basically will be focused by the cornea, and also the lens implant measurements and final visual outcome of cataract surgery. This condition is a slowly progressive condition. As you can see, we can see great white to bluish nodules or just elevations on the superficial layers of the cornea. And potential causes are those with chronic dry eye disease. Again, this is another topic that we need to talk about it further, but it's very important to be taken care of really well to prevent other cornea conditions to happen, which one of them is Salzmann nodular degeneration. Eye inflammation contact lens overuse, blepharitis, or condition of those oily glands that are located in our eyelids are all could be the causes of Salzmann nodular degeneration. Surgical indications would be eye discomfort, foreign body sensation, regardless if they have cataracts or not cataracts. Sometimes we need to go ahead and remove these for patients. These also can cause, visual blurriness because of irregular astigmatism, which is when the surface gets really not nice and smooth, the astigmatism happens. Some shadowing or shades again, next to the letters can be seen, and that will be reduced once the surgery is done. Obtaining accurate measurements is very important for lens implant too. So a lot of times when we need to go ahead and do cataract surgery, we will do this surgery first to make the cornea surface nice and clear before we want to go ahead and proceed with cataract surgery, because this is one of the most important things. We need accurate measurements. Otherwise, we're not going to get the final visual outcome that we're looking for. Again, the other thing that it helps when we take care of this prior to cataract surgery is that it does reduce the risk of glare, and it does optimize cataract surgery visual outcome because our measurements will be better. The risk of glare is less too. And surgical options, again, the same procedure I'll show you. The superficial keratectomy is one of those that can be included with phototherapeutic keratectomy, which is a type of a laser. Usually superficial keratectomy is enough. We go ahead and we can lift up those bumps, but sometimes in order to reduce the amount of haze, we also go ahead and do the laser to optimize the outcome. Okay.
This is actually a perfect time to answer that question. It looks like one of our attendees was actually foreseeing the future with that slide. Their question was, what are the pros and cons of the superficial keratectomy versus the PTK laser? And when would one procedure be preferred over the other?
Very good question. Very good question. Superficial keratectomy itself is very minor procedure. We just remove those lumps and bumps, but there is a chance that we can have more residual. So, the Salzmann nodules, let me just go back so I can show you the here. So these go to inner layers of the cornea, not too deep, but they're not just superficial. So with the superficial keratectomy, when we just remove the endothelium, sometimes we try to go underneath the bump. Basically, it's like a scab on the cornea. So we go underneath the scab and remove the scab. But we should not go deeper to the layers, because that can cause further scar tissue formation, So then we can have some residual opacities or grayish areas that can affect visual outcomes. So that's when PTK comes into place, which helps with minimizing that haze. However, PTK is a laser and also could be associated with further dryness. So we have to kind of balance the risk and benefits and see, okay, is it subtle enough that with the simple superficial keratectomy, we can take care of this? Do I need to go ahead and do PTK or two? Am I going to worsen the cornea condition? The dry eye condition? Is there any dry eye condition or not? Sometimes with my patients who have some dryness going on too, what I do superficial keratectomy, but instead of doing laser, I put amniotic membrane on top. Amniotic membrane, again, is a whole another conversation or discussion that we should have at some point later on. Is a tissue that is processed at eye bank from a placenta that's donated to eye bank. It does have a lot of anti-scarring effect. So that's another thing that we can do in replacement of PTK. But yes, PTK could be associated with some dryness problems and some scar formation too, but it minimizes the haze, basically. And that's why we basically sometimes need to consider that in more significant cases. So this slide, is there any other questions? Am I good? Yes? Okay.
Yeah, no, not at the moment.
All right. Okay, good. Very good question. Yeah. So this white lumps that you see over here, we're basically with the simple and this So there are techniques that we examine these. So not all those pictures are here. When we have it like a slit beam over here, we can see how bumpy they are and how further they're actually extended into the corneal layers. If they're not too extended, you see this beautiful result after surgery. So remove these and then the cornea becomes so clear. Not only clear cornea is important, but also visual outcome is very important, because when you do corneal mapping, you don't see that much of astigmatism that this eye had, even without doing cataract surgery. And that is going to tell me, it saves patients from having toric lenses, which help with astigmatism. So by just doing this simple surgery, we save patients from needing advanced implants in the future. So that's how it actually affects. This patient had really huge one here, and this was done. And look at the after surgery results. The more they get thicker, they push on the cornea, they flatten the cornea, the higher astigmatism we will have. So it's very important. So these cases are the cases that they definitely need surgical approach. But if you have subtle ones, just like very small ones, not significant astigmatism, patients not bothered by the symptoms, we can watch them. All right, so a few things about phototherapeutic keratectomy, not only for Salzmann nodular degeneration, but also it can be used for other things, such as band keratopathy. I showed you another picture about how the calciums can deposit. We can use a certain medication for that to basically eat up extra calcium deposits. And also, in addition to that, we can do PTK to ensure further reduction of the haze. Recurrent corneal erosions, if we have like that dystrophy that affected the surface layers and we get recurrent sloughs off, we can do we can do the PTK in addition to superficial keratectomy. Corneal dystrophies, I didn't get to that topic too much because that's again another detailed section. Genetic stroma or the mid layer of the cornea can be affected by different cornea genetic conditions that PTK could be helpful prior to considering complete transplant surgery. So, we always want to start with the least invasive and advance to more invasive if necessary. And then scars, it can help us. And then see, like, this is the thing. So this right eye had some residual haze over here, and this is the left eye. In some dystrophies, this is what exactly you see as well. And look what happens after PTK. This eye recovered so much. This eye is better. You still have some because that's a deeper kind of like layers, but you definitely see a lot less haziness, therefore better vision. And then we can consider cataract surgery. All right, last but not least, I guess this is the last thing I'm going to talk about. These are the most common ones. This is not, all the stuff that could affect the outcome of cataract surgery, but these are the most common stuff that we see. Pterygium or surface eye basically is an elevated, vascular, thick, scarred, fibrotic area of our clear part of the eye due to ultraviolet light mostly, and also it does have genetic factors to it that grows over cornea and affects the vision itself. Because again, there's a lesion growing over cornea, flattening that cornea at that area, and then give patients a lot of astigmatism. So this is another thing that if we see prior to a cataract surgery is going to optimize outcome. Why? Because again, the measurements will be better. After cataract surgery, patient is not going to have too much of astigmatism left, and we will make a decision whether after removing this, if still patient needs any astigmatism correction. And again, for those who have milder versions, they do definitely need to always watch out for progression and also protect their eyes against UV. So no matter whether we do have it or not, we all need to protect our eyes against UV regardless. So take home points, just to summarize things. Overall health of the eye is very important to achieve best visual outcome following cataract surgery. So it's not only we have cataract, we take the cataract out and patients can see better. We have to look at the whole eye and take care of everything that is existing prior to jumping into cataract surgery. Okay. Any coexisting eye condition should be addressed and managed in a timely fashion prior to proceeding with surgery. And again, it's all about reaching what our goal is with cataract surgery. And cataract surgery should be performed not only once best possible, eye surface health is achieved, but also when other eye conditions such as retinal disorders are stable. So that's another category. So again, we see patients, and if I see like some sort of retina issue is going on, I would definitely send to one of our retina colleagues here. We do have an amazing team to, take care of the patient, see if there is anything, basically clear the patients prior to proceeding with cataract surgery. And last but not least, not every patient would be a good candidate for different implants that are available. So we have amazing implants, multifocals, Panoptics, which is a trifocal. We have Vivity, which is extended depth of focus, which gives you the distance vision, close-up intermediate, vision, and mostly they can have a very good vision close-up. Sometimes for fine prints, they may need to wear glasses. We have the most latest FDA-approved light adjustable lens that fine-tunes vision after surgery. So we have a lot to offer, but all of them, depends on which patient is a candidate for. So patients come to me and say, oh, my neighbor did this, I want to do that. Not necessarily we can do the same thing for everyone, just because we have it. It's beautiful to have it, but we have to be wise about deciding which, implant is best for which patient. Okay, so different eye conditions determine the implant that each patient benefit the most. All right, I would be happy to answer any questions that anyone would have.
It does like we do have a few coming in. The first of which is having a dry eye condition affect affect or prevent you from getting a multifocal lens as far as cataract surgery is concerned?
Not necessarily. If we get it under good control, patients might be a candidate for multifocal implants.
And then what's the frequency of the various complications which must be kind of mitigated prior to cataract surgery?
Sorry, just say it again. I just didn't get
Yeah.
it.
So the question is, what is the frequency of the kind of the various complications that might be mitigated prior to cataract surgery? So how frequent, the things that were breached today during tonight's topic, kind of what's the possibility that one might run into it? Yeah.
Well, I might be biased because I'm specializing in this. So I get a lot of patients, and I'm a cataract surgeon, so I do cataract surgery, but I do see a lot of patients with cornea conditions. So not all of my cataract cases do need any of these things that I talk to. Almost, well, I'll just correct myself. I'm not biased if I say 90% of my patients, they do have dry eye condition, but at some different level or stage of the disease. So no matter what, I do see that a lot. I have patients who I was able to get them ready for the surgery in a matter of, a couple of weeks to a couple months. I've had cases that I had to work with them for over a year to get them ready for the surgery. And I'm happy I did that because they're very happy now. I want my patients to be happy. So, and be comfortable after cataract surgery. So, but for the cornea conditions, I might be biased because I do get those cases. So if my colleagues see like Fuchs dystrophy, they're going to send the patient to me because the patient might be in need of kind of a combined cataract and DMAC surgery at the same time. Or I do see a lot of EBMD or epithelial basement membrane dystrophies. Salzmans are always, there, but sometimes not picked up. So again, that question is very good. How common these conditions are, they're not uncommon. The ones that I talked to you today. And that's why I chose those for you today, because these are the ones that we commonly see. And it's very important to be picked up on time prior to cataract surgery in order to help us with deciding the best implant and also the visual outcome after.
And this is a popular question that we see quite frequently, and that is, are there any issues with cataract surgery in diabetic patients or patients on blood thinners prior to cataract surgery?
Blood thinners, not too much, not at all. I usually don't ask my patients to stop their blood thinners. You know, my anesthesiologist called them and asked them about the the blood thinners. Sometimes for certain type of anesthesias, it's important to know because we, sometimes give a little around the eye anesthesia, and that can be associated with a higher chance of bleed in patients who are on blood thinners. But overall, for cataract surgery, there's no significant concern for blood thinners. And diabetes, however, that was a very good question. Well, in diabetics, let's say a diabetic patient comes to me, doesn't have diabetic retinopathy, so the retina is not affected by diabetes, but their A1C level is high. Usually, I do tend to have the patients get their A1C level around 8 or lower for me to proceed with cataract surgery. Why? Because even if their retina is not involved, they're more prone to delayed healing, higher chance of infection, and latent retina swelling. So therefore, I will definitely not only take a look and see, okay, do they have any retinal involvement, but also I'm going to make sure the sugars are under good control and A1C is okay. Otherwise, I'm putting them at higher risk of developing any of this mentioned things after cataract surgery. So it's very important, the A1C level, blood pressure control, and not just blood pressure, I mean the sugar, but also blood pressure and cholesterol control to again have the least amount of what's called potential risks and complications after cataract surgery.
That kind of leads actually perfectly to another question about kind of the retinal and retinal detachments. And that being, what precautions are taken with high myopia patients, in this particular case, a -8 for optimal biometry, and how often do retinal detachments occur after cataract surgery?
Sure, that's a very good question. I do get a lot of high myopia patients with really large a lot of high prescriptions. Well, there are certain techniques that, first of all, and that's another important thing about cataract evaluation, because we see the patients, we know that they're highly myopic. The eye is really longer than the normal eye. So in the techniques that we use, we change or we consider that during the cataract surgery to make sure that, okay, this is a longer eye, this is a more high risk eye. So what techniques we can actually use to minimize the amount of risks associated with the cataract surgery? Number one, biometry and implant calculations. We do have a lot of different formulas. The best formulas, I mean, the most recent and approved formulas for implants that we do in high myopes or very nearsighted patients that help us with achieving what we want. Certainly, again, high myopes have a little bit different sort of kind of a decision on what power of the implant we put in their eyes, because they don't necessarily need what their normal eye and not myopic eye need. But these are the things that are also very important. We make a note of that, and then we do everything that is should be done for high myopes in terms of technique of the surgery and also the implant measurements. In regards to retinal detachment risk, obviously, again, the complete retina examination prior to cataract surgery is important because we want to look for any retinal tears and not necessarily detachments. Detachments would be really visible a lot of times, and patients would be symptomatic. But small retinal tears, sometimes we do not see it unless we do a very complete detailed examination. So we want to definitely get that examination done prior to cataract surgery. We also take some pictures just to confirm what we see. And also we monitor those patients closer. So any sort of, we give them warning signs. So a day after surgery, I see them, a week after surgery, and a month after surgery, sometimes even, more frequently. And I always tell them, if you see any new floater or, flashing lights, so it's very common to see more floaters after cataract surgery in any case, regardless of high myopia. But in high myopes, I have a very low threshold to get them in the office to check the retina again. And our retina colleagues are here for them too. And, very rarely happens. Maybe out of all this almost 4 years, I can't believe I'm here for almost 4 years, but, but I only had one patient who developed retinal tear after cataract surgery, which Dr. Jute took care of the laser, and patient did fine and no retinal detachment happened afterwards.
And you kind of touched on this, but it kind of segues. Well, after cataract surgery, is there any chance of floaters decreasing or being cleared?
Actually, usually it's been reported that floaters will get worse, because of the changes of the pressure as we, enter the eye. But most of the patients will get used to it, and the amount of floaters won't really bother them much after a few weeks to months. So it's not a big issue, thankfully, that we have been seeing, unless the surgery is complicated by other things that can happen during the surgery.
Can a multifocal lens by chance cause dizziness or have a major problem with people that might suffer from motion sickness?
Yes, there are reported cases of that. Yes.
Um, do you often prescribe Excedra for those with severe dry eye? And how long before being prescribed with Excedra to help reduce inflammation? How long would that take prior to cataract surgery for kind of the severe dry eye ocular surface issues?
Right. That's a very good question, too. Yes, I do often prescribe that eye drop. However, that doesn't work in every case. So if you are diagnosed with dry eye disease, you're not necessarily a candidate for Xiidra, because Xiidra is an immunomodulator. That means that if there is any inflammatory factor, not letting your glands provide you enough tear film or tear production is involved, then Xiidra might be helpful. So there are some testings that we do prior to starting our patients on Xiidra, or once we do see not much on clinical exam, but patient is very symptomatic, it has been shown to be very helpful. Usually for Xiidra, it takes about 3 to 4 weeks at least to start showing its effect. It's better than Restasis in the amount of time that it takes to become effective, but at least a month. In the meantime, I'll do other things too to speed up the improvement of the eye surface health.
And then we have two more, and then no worries if you aren't able to get your question in also tonight. I know if you're anything like me, it takes some time for information to sink in, and then I have questions popping up throughout the rest of the week.
Sure.
Feel free to email us at marketing@harvardeye.com or the same email that you registered with tonight, and we'll be happy to kind of answer those questions after the seminar or after tonight's webinar has concluded. But we do have, it looks like, 3 more questions. And that is the posterior capsulotomy included in your area of expertise?
Of course.
And is it
Of
related to
course.
any of the symptoms that we went over today?
Related to one of the symptoms already mentioned. No. Posterior capsulotomy. So posterior capsulotomy is a laser that we do very commonly for patients after cataract surgery. Almost 80% of the cases, starting from 6 months, some of them even sooner, but 6 months to 2 years after surgery, they start building up a little bit of a film behind the lens implant. So I always tell my patients, once the cataract is out, you're not going to ever get the cataract back. The medical term, however, for it is secondary cataract. meaning there's going to be kind of like a blurred or film behind your lens implant, which medically we call it opacification of the posterior capsule or the capsule that is containing the implant, or secondary cataract. That very easily with laser we can take care of that. And it's very common, and yes, I do those as well, but it's not associated with any of these topics. So not having any of these conditions will put you at risk of developing that after cataract surgery. They're not related.
Two more, and that is if a person has glaucoma and may have to have cataract surgery, is the outcome affected because of that glaucoma?
Well, of course, it depends what stage of the glaucoma, what type of the glaucoma. There are different types of glaucoma. There are different stages of glaucoma. Sometimes patients with glaucoma, they will actually benefit from combination of cataract surgery. Not only cataract surgery can help patients with glaucoma, especially with those who have high pressure glaucoma, because we do have normal tension glaucoma as well. But with those who have higher pressures, cataract surgery will be very helpful, not only to give them better vision, but also to take care of the glaucoma part. But in those cases, we actually do some combined cataract and what we call micro-invasive glaucoma surgeries. I do those as well, although we do have Dr. Wang and Dr. Timorian here doing those combination of cataract and glaucoma surgeries. Sometimes I do have my cornea patients that I do need to do that for them to get their pressures under better control. So I do a combination of the two. But outcome really depends on how bad the glaucoma stage is.
And our last question for the evening, and that is, what's the right time to measure between the eye and then the actual day of surgery?
If you have a fine eye, so let's say we do the cataract eval and I say, okay, everything is fine, so let's go ahead and schedule, and you would like to go get scheduled, there's not really a time being that I say, oh, it should be done a week before surgery or a month before surgery. Doesn't really matter. I usually tend not to do it further than 3 months from the surgery time, because in that 3 months, a lot of things can change. And as a matter of fact, if I do see a patient now and the patient says, okay, I would want to have surgery done, but not now. I want to have it done in fall. So I tell my patient, please come back so I can see you beforehand, because from now until fall, things can happen and the eye surface can be changed, So that's very important. But let's say if patient has any of these conditions that I talked to you, like Salzmann nodules, or has kind of like dryness, or it has sort of epithelial basement membrane dystrophy, I do any surgical procedures such as superficial keratectomy, PTK, I wait at least 8 weeks until the patient after the superficial keratectomy or PTK before I want to do measurements. So I give it, before we used to say 3 months, but now somewhere between 8 to 10 weeks after superficial keratectomy, PTK, or any cornea procedure, we can go ahead and do, it's the best time to do the measurements prior to cataract surgery.
Wonderful. Well, thank you so very much for a wonderful presentation. And thank you everybody for joining us on this Wednesday evening. We're always very fortunate and love putting these on. So we appreciate you spending your evening with us. Like I mentioned, if anybody does have any questions, please don't hesitate to email us at marketing@harvardeye.com. And we'll be happy to go ahead and get those questions answered for you. And I guess before we sign off for the evening, Dr. Rouhani, any last words?
I just wanted to thank you everyone for being here, and please let us know if you come up with any questions. You're more than welcome to still send us any questions, and I would be happy to be of any help for anyone that would need. Yes, have a good evening.
Yeah, thank you so much. And also, just in case, we went over a lot of different topics tonight. If you missed something or kind of would like a refresher, you are also available to watch the presentation one more time in the entire webinar on our YouTube channel, which is just Harvard Eye Associates. So you'll be able to find it there as well. But on behalf of Dr. Rouhani, everybody here at Harvard Eye Associates, and myself, thank you so much for joining us this evening. And we hope to see you soon and help answer your questions.
Thank
Take care, everyone.
you. Thank you, Michael. Good evening. Bye-bye. Have a good night.